making. I think I mentioned this like on the first day, and it probably just went like right through your heads, but one of the things that we're moving towards in this class is you learning to think critically. And that really is something that, we all should have learned when we were about 5 or 6 years old. They don't really teach that stuff in school. Most of what schools are training you to do is to read some information and regurgitate it. You're not really learning how to use that. It's kind of like taking a foreign language. You can learn all those words. Like I took Spanish. I never quite grasped the whole thing. But I learned all the vocabulary. If you give me a test with all these vocabularies, I've got it. But once you start having to conjugate verbs and once you have to talk to a native Spanish speaker, Grace, if you're listening to this, talking about you guys, Grace in our class, then you learn that you really don't know anything because you can't just take memory and make it work.
You don't teach how to speak it either, you teach you how to write it.
Well, whatever. It's a hard thing to grasp. Same thing here. You can learn all this stuff. You can read that book. You can spit these answers out. But you've got to learn to be able to take that information and apply it to a life or death situation. You have to be able to apply it to a good assessment of your patient. I can tell you about a patient who's jaundiced and a patient that's, very red or very pale, but until you've actually seen that and thought, oh, they're really pale, we're not getting some blood flow here. So you have to be able to learn to use that information. So this chapter is about critical thinking and decision making. And this is really what separates us from so many other professions out there. We have to think very quickly, make decisions very quickly based on limited information. We can't get a patient's blood gas. We don't have x-rays. We don't have a lot of those tests at our disposal. So we have to look at a patient. Our eyes really are going to be one of our most important aids in helping us do a patient assessment. But we've got to be able to use our brain. So that's what we're going to talk about here briefly in this chapter. We're looking at making a diagnosis. We're going to talk about a differential diagnosis. I hope it's in here. How we make some of these decisions and how we can learn to think like a more experienced provider. And I think I mentioned early on, here just a second ago too, that we really behave differently than some of the other healthcare providers. One, because we don't have all those tests, but also we are looking for what's going to kill a patient. Some of the other professions, they all have their little slice of what they're looking at. We really want to see what's going to kill you. I'm not looking to see if, you're taking your medications properly or, are you not doing this or not doing that. We're looking for what's going to kill you. And in the ER physician, that's at their top of their list. What's going to kill the patient? And then they kind of go out from there and prioritize with how important something is. So certainly they're going to treat whatever comes in, but they're going to prioritize the people that are going to die from something, and then they're going to go down the list in priority. And so that's one of the reasons that they've kind of linked us here in the way physicians think in the emergency department, because we're looking for what's going to kill your patient. Okay. A diagnosis really is going to be identification of what we think is wrong with the patient. And we're going to reach that diagnosis based on, a lot of it's going to be on the history that we get from our patient, as well as the results of our physical exam that we do. Bless you. We recorded that sneeze, Should we say your name on there so everybody knows who sneezed? No. They'll recognize it if you continue to do it. We'll embarrass you. But you're getting your vital signs. You're doing your assessment on your patient. You're doing your physical assessment. But a lot of what you're going to get is going to be based on the history of present illness that your patient gives you, particularly, for a medical patient. It involves both physical and intellectual activity. So we're physically going to be assessing our patient, but it's what's going on in our minds that really make the difference. Us being able to take that information, sift it, and make something out of it. I remember in the older days when I was an EMT, before I went through paramedic school, and I remember watching the paramedics work and thinking, they don't do anything. Oh, they don't do anything. They mostly sit there, they ask the patient a million questions, and they don't do anything. know what, it's all going on up here. They do their physical assessment just like we do at the EMT level, but a lot of what's going on is going on up here. They're sifting out what's going to kill this patient, you know, when they're trying to make their diagnosis. So sometimes looks can be deceiving. Okay, how do we reach a diagnosis? Based on our training, our experience, how much time we have, and what our resources are, those are going to dictate really how well and how we're going to reach our diagnosis. As I mentioned, in the emergency department, the hospital, they have just this whole multitude of tests they can run that help them reach a more definitive diagnosis. For us, ours is usually going to be much more generalized because of the information we have. Techniques will vary based on where these assessments are taking place. If you go to the physician's office, you go to the doctor's office, you know, because your back's been hurting you, or whatever, I've been having headaches. What's going to be their process? Are they going to make a diagnosis like this and, you know, do something? They're pretty slow. They're just very thorough. They're like the tortoise, and I'm personally like a tortoise, so I appreciate that tortoise analogy. But they're much slower about it. They're going to order tests, and you're going to come back, and they're going to check you again, and they're going to order something else. They'll try this and see if that works. So they kind of go through this long, drawn-out process because they have the time for it. They have the tests that they can run. In the emergency department, how do they compare to what goes in the physician's office? It moves a lot faster. Do they have tests that they run? Yeah, can those take a while? Yes, but they also can come back fairly quickly. I mean, it wouldn't be unusual for you to go to the emergency department and be done and wrapped up with your diagnosis and your treatment and got everything squared away within 6 hours. You know, if you go to the, it's possible. Hey, it's possible. It's possible. Or in the physician's office, they usually take weeks and months to work through something, right? You know, you just kind of keep going at it, you adjust your medication. In EMS, what kind of tests do we have? Not very many. How quick do we have to be? Pretty quick. You know, you walk into a patient's house, you got to make a decision within sometimes a few seconds about, is this person fixing to die? Am I going to have to bag them? You know, what do I have to do very quickly? So we're really fast at it. So our techniques are going to be a little bit different. We're going to be looking at things a little bit differently. So for those of you that are considering going on to nursing or PA or something else, your assessment process is going to be a little bit different. It's just like I've looked at some of the nursing pharmacology books, and I'll see some of their medications or some of the same medications that we would use or give, but the dosages or their delivery routes are very different because they have different goals with that than we do. Okay, traditional approach to diagnosis. You know, you do your assessment and you do a differential diagnosis. Does anybody have an idea what a differential diagnosis is? Yeah, your potential diagnosis. You might, you've got somebody with, say, a rash. What kinds of things could be causing a rash? You could be having an allergic reaction. What else could you be having? I've got a rash.
Poison.
I could be poison. I could have the measles. I could have chickenpox. Well, that'd be a very odd rash. But yeah, there's different things that it could be. So I'd start out with my list of my potential diagnoses. It's kind of like at the top of a triangle. Now we're going to start ruling things out. If I haven't been exposed to anything that could cause an allergic reaction, that's going to narrow that down. If I have, well, that's going to narrow that down. You know, if you can take away anything that you can discount. You know, it can't be this because this. You know, they've got abdominal pain. Could it be appendicitis? Sure, until we rule out the fact that they've had an appendectomy. So now we know it's not appendicitis. So you start at the top with all your possible diagnoses, and you kind of go down from there. You pare them down as you're able to discount them for one reason or another, and then you come up with your final diagnosis. In EMS, we usually have a working diagnosis, but we usually have maybe 2 or 3 things it could be. Sometimes we can pretty well pinpoint it, but sometimes we've got a narrow field. But regardless of what the diagnosis is, our main concern is going to be what? A, B, C. I may not know what's causing your respiratory difficulty, but I have a few ways I can manage it. So you may just kind of hold them together until they can do further testing at the emergency department. That's okay. We want to quickly rule out any life-threatening problems that the patient may have. Our goal is to stabilize them, recognize and stabilize them. If we don't recognize that they have a life-threatening problem, how are we going to know how to treat them? So our assessments are extremely important. We will continue to gather additional information which may help us with our differential diagnosis. And oftentimes that's going to be what the patient tells you. May not be so much a result of your physical assessment, but you know, they kind of drop the bomb on you that, you know, well, yeah, well, I've been taking this medication for such and such. It was like, duh. My mother-in-law she's in her 90s. She has chronic diarrhea. Did I tell you this? She has chronic diarrhea. And she's always coming that sick. Oh, why am I telling you that? Well, I'm telling you that because she can't understand why she has diarrhea. So one day we asked her for a list of her medications. You know, like it was about 5 pages of Microsoft Word. And we're looking through there and you start checking the, you know, the side effects. And it's like, there's like maybe 3 on the whole list that don't cause diarrhea. And it's like, Mom, if you don't want diarrhea, number one, you don't need to be taking 47 medications. She's with that group of people that thinks a little medication will fix everything. So yeah, gathering some additional information, sometimes you kind of go, oh, well, that explains that. I had a patient one time that she done fell out. She'd been playing bingo or something at the bingo parlor with hundreds of people in there. And she was sitting down and she wasn't feeling too good, so she popped one of her pills. And then she got up, you know, to go somewhere, and she just done fell out, and she stayed out. I mean, that's how it went. She done fell out. But anyway, we get there and I start asking her what was going on, and she said that she just kind of felt sick, so she took one of her pills. I said, well, what did you take? Well, one of these little pills was a nitroglycerin pill. And I said, well, did you have chest pain? No. Okay. So you took this little pill, then you got up and went to the bathroom, your blood pressure dropped, she done fell out. She'd been sitting there probably for hours losing at bingo. So just by the process of saying, well, tell me what you did. Did you take anything or what? She goes, yeah, I took these pills. So oftentimes, they're going to give you this information that you wouldn't expect to get. You know, she passed out, I don't expect that you just took a nitroglycerin because you felt sick at your stomach. So you have to ask a lot of questions sometimes. But mainly, you're looking to rule out the worst case scenario. She's passed out, you want to think of what could have caused her to pass out. First thing I'm going to think of probably is blood sugar or something like that, which low blood sugar is very life-threatening. So you want to rule out the worst case scenario and then kind of go from there. That's what we do. Worst case scenario is what? Something that's going to kill them. So we're looking for what's going to kill them. If you see a red flag, somebody that's wheezing, that's a red flag to me. Somebody with dangerously low blood pressure, that's a red flag. So you're going to learn certain little things that are going to go like little bells in your head that there's a problem. If you're seeing something, the same response in multiple patients, then you've got something completely different going on that you'll need to look at. But you need to be alert for that. You know, if that lady at bingo hall done fell out, and then all of a sudden we've got more people falling out all around the place, what am I thinking about? The food. Yeah, that's the first thing I think about is the food, and you know, was McDonald's catering or something. Probably. But you want to find out what's going on there. If it's in the air, you're going to expect a lot of people very quickly, right? That always scares me. Okay, our approach to diagnosis, we have to be very efficient. We've got to be, we got a quick turnover of our patients. In a busy service area, some of these crews that work 12 hours a day, they may have 15 to 18 calls in a 12-hour day. That's a lot. So we have to be ready to turn patients over quickly because you don't want to be tied up with, you know, Mrs. Jones, you know, she has a headache while you've got, you know, John Smith down the road that's waiting with chest pain because you can't get to him. So we have to be pretty efficient and turn patients over very quickly. We work in a very uncontrolled environment. That's probably why a lot of you guys are here. You like that kind of thing. If you don't like to sit behind a desk, you know, you like change. Well, our environment is very uncontrolled. We don't have, you know, heating and air conditioning in a lot of places that we are. We have limited tools and skill set. Our skill set is very narrow. When you look at what differentiates us from maybe some of the other, like nursing for instance, their information, their training is very broad, where ours is very in-depth. So, like I had a student the other day say, you know, I would really like to know more about EKG and rhythms and that kind of thing, because we really didn't get much of that in our nursing program. Well, you don't, because you don't really need it. You need to be able to recognize the ones that are going to kill you pretty quickly, you know, like in an ER environment. But for us, we need to be very in-depth to be able to read a lot of those strips. So we have a limited, it's almost like being a specialist. This is what we do, and we're very good at it. For instance, you'll get, over the course of your career, you'll get called to a primary care center, you know, a doctor's office sometimes, you know, or a pediatrician's office, or the urgent care. And you're thinking, you know, they've got doctors there, can't they take care of this? Well, they probably could, but that's not what they do. That's not their specialty. They're looking for people with colds and people with flu and, you know, people with twisted ankles. We're looking for people that are fixing to die, you know, or have just died. So we come with a different skill set. It's limited, but we're good at the small focus of what we do. So we have a narrow educational focus. That's what I'm getting at there. We go through our diagnosis steps the same as an emergency physician does. It's very quick. It's looking for key things that'll ring a little bell in our head that show there's a problem. If it's not something that's going to kill them, they're going to put them on the back burner, probably let the nurses do some further assessments there and evaluations. They're going to rule in or out things that are going to kill them, things that are very serious. This is what creates your differential part of your differential diagnosis. Keeping in the things that fit a diagnosis and getting rid of the things that don't fit that. Okay, you can reach a diagnosis, but your work is not done. Why? Got to do something about it. Particularly in EMS, if we've determined that that patient has a life-threatening something or another, we've got to act on that. So an assessment is part of it. The treatment is going to be the back part of that. You've got to keep your eyes open too, that patients frequently have more than one thing wrong. So they may have things that are, presentation is conflicting in that all of their signs and symptoms don't fit the pattern of one particular disorder. They may actually have two things going on, and you may have to separate those in your mind and say, yes, they're having an allergic reaction. They also have this going on, where you may have crossover signs and symptoms. So don't close your mind. Don't get tunnel vision on one specific thing, because it could be more than one thing, particularly as you get older. At one other point here too, if you think you've figured it out, don't stop looking, because you may be wrong. Very frequently, unfortunately, you have a patient that says they have chest pain. If it's atypical or it doesn't present exactly right, then you may say, well, then it's not that. You need to keep your eyes open and continue your assessment. Heuristics is something that you will develop over time, where if it looks like a duck, it walks like a duck, it quacks like a duck, well, it probably is a duck. Well, probably 98% of the time it is a duck, but you got to watch out for that 2% of the time where it's not a duck. So you just can't get that tunnel vision saying they meet all this criteria, so then it's this. So you got to keep your mind open so that you don't close off to something that is that may alter your treatment significantly. Shortcuts are good. You know, you'll get to the point where you can walk and you can pretty much look at a patient and with just a little bit of assessment have a pretty good idea of what's going on with them. But just don't get tunnel vision there. We develop biases sometimes because Mr. Jones presents just like Mr. Smith did 3 weeks ago, then they must have the same thing. Not always. Sometimes yes, but not always. But by using these pattern recognitions, oftentimes it does speed our diagnosis, but just be careful that you don't get tunnel vision with that. How you can learn to think like an experienced physician? You gotta love ambiguity. That means if you're the type that everything has to be just so, everything has to be perfect, it's gotta fit in, a square box, you're not gonna be happy in EMS. You're not gonna be happy as an ER physician. That's one of the things that we like. We like that change. We like the challenge that comes with that uncertainty. You got to understand our limitations, what we can do, what we can't do, what our technology can and can't do. Nothing's perfect out there. How do the limitations of technology impact our diagnostic technique? How about a pulse oximeter? You're putting your pulse ox on the finger. It says it's 82%. Can you take that to the bank, meaning your patient is poorly oxygenated?
No, they might have on nail polish.
They might have on nail
Hands
polish.
on.
They might be really cold. They might have peripheral vascular disease. So it's just a piece of equipment. You can't depend on it to be 100% correct. So technology, as far as it goes, but the most important part is going to be your ability to use that technology or make it work for you. No single way is always right. And this is important that you understand this, is we're learning our checkoff sheets, and I tell you, you got to go just like this. That is a tool of training so that you develop a process. It's like I give you the structure, but when you're out there practicing, you're going to fill it in a little bit differently, just as all of us have. We all got our bones, we all got our skeleton, but you all fill out differently. So we're going to give you the legal part of this and the structure of how you should do it. But when you go out there and practice, you're going to fill it in so that it suits you. Just like I said the other night on your trauma assessment, I go all the way down the body to the toes and come back and do the arms. If you want to, you can come down to here, the waist, and then do the arms, and then go on down. That's okay, as long as you get it all through, all in one swoop. So there's no single way that's always right. That's why they call it practicing medicine. We're still trying to get it right. But, it changes a little bit. And everybody's going to practice a little bit differently. You're going to develop different techniques, and that's good because people are different. So just recognize that you're going to have to find what suits you the best, the way your brain works. Remain open-minded. Keep your eyes and ears open. Learn to learn from other people. Now, I don't know about you guys, but I have 2 daughters, and one of them, I can tell her, I said, this is what happens if you do this. And she can learn from that, and doesn't fall in that hole. But now the other daughter, it doesn't matter. I can talk to her blue in the face. She's going to fall in that hole, and that's the only way she's going to learn from that. So everybody's going to be different here. But try to learn from others. Please don't fall in that same hole. If you've seen so-and-so kill that patient, you don't have to kill that another patient just so you can learn, how to use an EpiPen. Keep your eyes and ears open. Learn from others' mistakes. So always ask, what happened here? What do you think went wrong? What do you think we missed? Like, early in my career particularly, I spent a lot of time evaluating calls after a run. And anytime I worked with anybody that's fairly new in the field, I'd say, okay, look at what we did. What did you see? What do you think was going on? Based on what happened here, what could we have done differently? What would you have done differently? So with all of your calls, and even any that you're around, you need to think about that. What could we have done differently? What did I miss? What should I have done? What would have led me down to that diagnosis better? Make sure you have a strong foundation of knowledge. That's one of the biggest problems I have about taking this course in the summertime. It moves so fast, you're going to miss stuff. So make sure you go back and refresh this stuff, reread this stuff as you go through, because you're going to miss stuff. And you may miss something very important and not even recognize it. So always be studying, always be learning. I mentioned earlier that you need to start making note cards as we move through trauma and move through medical. You need a note card on every single thing that can go wrong with a patient. Signs and symptoms, and then treatments. When we look at some of the drugs, you're going to need to know what they are, what they're indicated for, contraindications, you know, drug routes, dosages, that sort of thing. So make sure that you're familiar with things. If I said your patient presents, he's got some respiratory distress, he's been coughing, you're called out at 3 o'clock in the morning, and he tells you that he's been feverish and he's been having night sweats.
Oh, TB.
Yeah, the first thing you want to think about is tuberculosis, because night sweats is one of those things that's a hallmark of tuberculosis. But now if you've got some 65-year-old woman and she tells you she's waking up with night sweats and she's not having any respiratory distress or coughs, are you thinking TB? No. So you need to be familiar with what signs and symptoms go with every condition out there, so that certain little things will ring a little bell for you. It doesn't mean it's exact, but it should lead you down that path. But you got to be familiar with them first. Like a minute ago, we were talking about a narrowing pulse pressure. Now, you should have taken that information and tucked it back in your brain. I said a narrowing pulse pressure very frequently indicates blank. So if you tuck that in your brain, do you remember? There's something in the chest, particularly we see pericardial tamponade, but there's something that's preventing the heart from doing its thing, expanding and contracting. So that's one of those things that if you read somewhere or you notice that your patient's blood pressure, the pulse pressure was narrowing, then all of a sudden it's going to go ding, 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 and you're going to think, oh, there must be something in here preventing the heart from expanding and contracting normally. So you've got to be familiar with the different conditions. Okay, other things. Continue learning, I said that. You need to be organized. You need to be constantly learning. Things change all the time, particularly in medicine, like nothing else out there. Math doesn't change that much. I hope not. You know, other stuff doesn't change. History, we sometimes rewrite history, but history doesn't change. But medicine changes. Things we do today, we didn't do 10 years ago. Things we did 10 years ago will kill a patient today. Killed them back then too, but we just didn't recognize it. So medicine is constantly changing. Like medications, for example. I'm not going to give you a list of medications and say, what does this do, this do, this do, this do, except the ones that you're going to be giving, because medications change over the years. You know, every day they probably bring out 20 or 30 new medications every single day. So there's no way anybody can keep up with every single medication. But you do need to be constantly learning and reading and thinking about integrating what you've learned. Okay, what are some of the important things to remember as you learn how to make a diagnosis and improve your critical thinking skills? Somebody, one thing. What's an important thing you need to remember about making a diagnosis? It can change as what? Yeah, as you're learning more, reassessing your patient, your diagnosis may change. What else? You could have more than one thing going on, so don't kind of get tunnel vision. Anything else? Don't wake me up and let me think.
You could be wrong.
You could be wrong. Just because it looks like a duck, acts like a duck, smells like a duck, whatever you say about a duck, it may not be a duck.
Start with the worst case scenario and work from there.
Exactly. Start with the worst case scenario and rule that out. When you're doing your differential diagnosis, what's the worst this could be, and does that line up that it fits? If it doesn't, that's good. Move on to the next thing. But you're absolutely right. Look for the worst thing. Rigid diagnosis is a process that can be learned through study, practice, reflection. You're not going to be good at it that first year out. I remember when I came out of paramedic school, I asked one of my instructors who I was working with, I said, how long before you really feel comfortable every time you go out there that you're going to be able to make a good assessment and treat appropriately? He goes, oh, probably about 2 years. It's a long time. I can kill a lot of people in 2 years. But you know, he was exactly right. It was just about 2 years before you've seen everything, pretty much everything. You've experienced just about every kind of patient that you can encounter in that length of time. If you're in a busy service, I was in a busy service. But it's going to take you a while before you're comfortable that every time the tones go off, you go, I've got this, and I can't wait to see what it is. up to that point, you're kind of going, please, I hope it's not blank, because
I don't
I'm
wanna
not
know
good at it.
that.
Yeah. I don't know if I told you guys, my first call as a paramedic was a pediatric anaphylaxis. Number one, pediatric, you see less than 10% of the time, and we really don't see that much anaphylaxis. So the first one right off the bat, you got to give a drug to a little kid. So you can imagine how I was feeling. Probably about the way you do, you know, like at final exams, you go, if I don't pass this, you know, I'm going to die. So, yeah, if I don't get this right, somebody's going to die. So yeah, it's going to take you a while, but practice is what makes perfect. When you leave here, you'll have basic knowledge. That's what you're going to have. And then as you get experience, you're going to build on that. You're going to fill that out. You leave here with your skeleton. As you move forward, you're going to be filling it out so that pretty soon you've got all the working parts. I hope. Chapter review. We make diagnoses in the field. They're non-extensive. They're not as detailed as they're going to get, of course, in the hospital environment. Traditional approach, what I leave out here, is reaching a diagnosis is assess the patient, draw up your list, form your differential diagnoses, rule them in, rule them out, until you've narrowed it to the point where it's workable. Highly experienced physicians, they don't always use that traditional approach. They use heuristics where they're looking at, I've seen this before, does it fit that same pattern? What are the limitations of this approach?
Getting on down, like you could be thinking the same thing.
Yep, you get tunnel vision, and you just can't do that. You gotta learn more, think critically, understand limitations. I already told you that. When considering the cause of a patient's condition, don't let your search for a cause delay your treatment of the patient. Because does it really matter, the bottom line, if they've got severe respiratory distress, if we understand why they have severe respiratory distress? No. The important thing is we manage severe respiratory distress. I already told you. Y'all go back and read all these, don't you? You do not. Okay, a couple of them. Patients often have more than one thing. Don't stop looking. Even when you're sure you're going down the right path, don't stop looking, because there's going to be something else out there. 52-year-old man complains of chest pain while sitting at his desk at work. He appears alert and oriented. He tells you he thinks it may just be stress. How would you arrive at your diagnosis?
Vital signs.
All right, we're going to get vital signs. If they're out of the norm, then we're going to be alarmed. What else?
Past medical history.
Past medical history. Has this happened before? You know, have you had chest pain? You know, if it's a guy that says he's got chest pain, he thinks it might be stress, but he's had, 3 open heart surgeries, he takes a whole slew of cardiac meds. Are you more concerned about him than you might be 25-year-old that says she's got chest pain? You bet. So medical history is very important here. So what other things would you look for? Done vital signs, you're getting some history. Have you had this before? This is where you're going to do some of your OPQRST, right? Where does it hurt? What does it feel like? How long have you had it? Have you done anything to make it better or worse? That kind of thing. Trying to rule out just stress. I love this slide. Don't you? We don't flip a coin, do we? We're going to get a good differential diagnosis.